Sex Talk with the Siegel Brothers is a weekly program designed to answer all your questions, including the ones you didn't even know you had, and to clarify the endless debates around the wonderful and fascinating world of sexuality. Join us for real talk about sex from two experts in the field. Richard and Larry Siegel have over 50 years of experience as sex therapists, educators, counselors, and researchers. The Siegel Brothers are recognized around the world as trainers of medical and mental health professionals.
Hello, and welcome to Sex Talk with the Siegel Brothers. I'm Larry Siegel, a clinical sexologist and certified sexuality educator.
And I'm Dr. Richard Siegel, a certified sex therapist and supervisor.
Thank you for joining us tonight. It's our night to be with you to talk about sex. And even though we do like to point out that every night should be sex talk, we appreciate having this time to spend with you to talk about the things that we would like to share with you.
Yes. And on the subject of sharing, we'd be so grateful if you would share the link to this broadcast and subscribe to our YouTube channel and let your friends and family know how important it is to have at least weekly conversations about the important topics of sex and sexuality and sexual health and family life.
Indeed.
People are afraid to talk about family and sexuality in the same breath, even though that's how people have families.
Exactly.
Right? Yeah. So last week on the show, we were talking with our dear friend Lori Shapiro about why pregnancy and the whole field of obstetrics is so sexless.
Yeah.
And the very thing that makes people obstetrics patients, sex, doesn't get talked about through the whole process.
Exactly.
Right?
Exactly.
But this week,
we can talk about it.
This week you got to step it up.
That's
to
right.
a much, much more serious level.
That's right.
These two very powerful words that I had not heard put together in this context, but yet when you think about it for more than a second, you realize how common, that's the way it is. The words are obstetrics and violence.
Yeah.
And so tonight we're going to have a very powerful discussion with a dear old friend and colleague, Dr. Amy Gilliland from Madison, Wisconsin, to talk about obstetrical violence.
Indeed.
I'm Rachel Needle, co-director of Modern Sex Therapy Institutes. And Modern Sex Therapy Institutes is a continuing education provider. We provide continuing education for medical and mental health professionals around the world. And we have over 140 archived workshops on our website, so please check them out at www.modernsextherapyinstitutes.com. Also, we have a number of certification programs, including sex therapy, couples in sex therapy, LGBTQIA affirmative therapy, alternative relationships, transgender mental health care, medical sexology, sex education, and sex counselor certifications. In addition, we offer a PhD in clinical sexology. So please, again, go to our website, check out everything that we have to offer. A lot of our stuff is available solely online from the convenience of your own home or office. We do things live in 8 states and live via webinar as well.
Amy is a trainer of birth doulas. Doulas assist women in the birthing process, of course.
Indeed. Which is very similar to a midwife. And for anybody who's not quite sure on the distinction between a midwife and a doula, the midwife is usually a nursing certification. It's more medical training. And like obstetricians, they're really mostly concerned with delivering a healthy baby, right? Which is a slightly different perspective from a doula. Not to say doulas aren't interested in healthy babies, but they're more interested in the health, safety, and the process of the mother through this process of birth.
And that's what we talk about. That's what we will talk about with Dr. Gilliland, and that's really at the heart of this very heavy topic. That women are often brutalized during the birthing process, and the message is tough. That's the way it's supposed to be. Get in there, do it, and don't complain about it. And this was very eye-opening.
It truly
topic.
was. It truly was eye-opening, and even more so to be able to realize how common this is, how often this happens. It's almost, this is the status quo for most women who are going through these medically assisted births.
Yeah. And to hear that in the 21st century, medicine is still as crappy to doulas and midwives as they were.
Yeah.
When were the Salem witch trials?
Oh, you can go back to the 1600s.
Another interesting bit of sex trivia in history, that a lot of those witches that were burned at the stake during the Salem witch trials were herbalists and midwives.
That's right.
This has been going on for thousands of years. Women who've been helping other women deliver babies.
That's
long
right.
before there's such a thing as obstetricians or maternity wards or hospitals, for that matter.
Right. And by the way, that you're going back to those times, that was also about the time where medicine was emerging as a specialized field, which was up until fairly recently in time strictly a male field.
And also important to elbow out the competition.
Right? That's right. That's right. So they may not have been called doulas back then, but doulas and midwives that have been around for a very, very long time. I'm glad to hear they're finally coming more out into the open, and more women should really kind of look at that as an option for their pregnancy needs. So I think you'll really enjoy this interview. Hopefully it's going to be really eye-opening for you as well.
Hello, and welcome back. And as promised, we are very thrilled to introduce our guest this evening, Dr. Amy Gilliland from Madison, Wisconsin. Amy is a research associate at the University of Wisconsin, Madison, in the Child and Family Wellbeing Department. She is a birth doula trainer, and we know her for many years through ASECT. Dr. Gilliland is a certified sexuality educator and supervisor of educators through our kind of professional home organization, the American Association of Counselors, Educators, and Therapists. Sexuality educators, counselors, and therapists. How did I get that wrong? It's only been
how could you leave the sex out of there? I don't know.
Right? Freudian. Well, welcome. And I'm really happy to see you and to have you on Sex Talk.
Yeah, I'm excited to be here.
So,
Well, thank you so much for doing this.
and this topic is as we said in the intro, a powerful one, and just a whole other level from the discussion we had last week about just simply why obstetrics and pregnancy tends to be so sexless, and nobody's talking about the thing that makes people obstetrics patients. It was just such a gut punch to hear this term obstetrical violence, that we just had to bring it to that level. And of course, you're the person that came to mind. And so welcome, and please tell us about this thing that people, women are told the message to women is they're not allowed to talk about any of this. They just have to accept what's going on. And tell us your view on what's wrong with this whole process, especially in America.
Well, I want to start first with a reference to Birthmonopoly.com. So if anybody wants to know more about obstetric violence, wants to take a course in it, wants to read more articles, or follow up, that would be the place I would send you, is to Birthmonopoly.com. And there's a film coming out called Mother May I, which is documenting people's experiences of experiencing violation during their birth. And you're right, it's a really powerful word, and people try to think, oh no, that can't be happening, because it's all about babies and babies being born and things happening. But when you look at the history of birth in our country, the whole field of obstetrics and labor and delivery nursing was found during a unique 30-year period in human history when people were drugged and could not participate in the decision-making about their birth. So obstetrics and labor and delivery nursing evolved as specialties without the patient.
Wow.
So the patient was totally not a part of the paradigm. And you can't imagine cardiac care, you can't imagine pulmonary care of your lungs, kidney care, GI care, any other part of the body where you have a problem, you have to develop the course of treatment with the patient. I mean, there's just no other way. But obstetrics, as opposed to midwifery, does that. And that is its history. And because of that history, it has a power over dynamic that I know what's best for you. You do not. I am the person with the knowledge that you do not have. And also, so there's that attitude. And also, physicians are trained to look at the process of birth, not the person birthing.
Mm-hmm.
And so, and this is really clear when you look at medical anthropology, that nurses and family practice doctors and doctors of osteopathy are trained to have a healing relationship with the patient. That is the core of humanistic care or biopsychosocial care, the way it's referred to. In the medical model or the technocratic model, the person is irrelevant. It is what's happening to their body that the practitioner pays attention to.
Mm-hmm.
So that makes sense if like you're having a heart attack or something, but it doesn't really make sense when you're actively trying to birth a baby, which is not an illness.
Right.
It's a wellness condition.
Right.
So the roots of violence start years ago when the foundation for this kind of practice began. And then we developed all kinds of lucrative systems based upon the silence of the patient and taking away their control and decision making. And so the way birth is financed is based on not what the patient wants for their birth, but based on what the doctor is ordering to have happen. So you have this patient who doesn't have a lot of power in the system. And that's reinforced by the way we do insurance. There's no way for you to opt out and say, well, I don't want this doctor. It's like, no, that's who you got assigned. Mm-hmm. And even if you don't want to see an obstetrician, you're like, well, I'm not high risk. I don't consider myself high risk. Maybe I needed progesterone shots at 12 to 14 weeks of pregnancy, but ever since then, everything's been fine. I want to see a midwife for my birth. No, you can't do that. So the insurance system also perpetuates who holds the power, and it's not the person who's birthing. So, but when we talk about violence, people are often thinking about, well, that's because stuff's happening against your will and you don't have a say and people aren't listening to you. And I'm like, yes.
Yeah.
That's exactly what we're talking about.
That is a point that I also want to just sort of throw into the mix as well, that especially when we're talking about obstetrics, but couldn't we make some of these same points about gynecology in general and the way women are often manhandled on the table? It's almost like what they want, their anxieties, their fears are completely irrelevant. And it's almost like a lot of gynecologists are sort of like, just shut up, spread your legs, and let me do what I need to do.
Exactly. And that's the attitude that leads to the brain encoding the experience as traumatic, because that's what brains do. That you have a flood of catecholamines, you got a flood of stress hormones. The brain is going, wait, something's happening to me and I'm powerless to stop it. I'm being treated like an object, not like a person. And I'm about to be violated in my integrity. I'm about to lose my integrity in some way, whether that's emotional violation, sexual, physical, but those three things are what causes the brain to encode something as traumatic. And even something, I'll tell you this. So I had a doula training last weekend. I've been a birth doula trainer for 23 years. So I have thousands upon thousands of birth stories in my head. I'm also a published researcher. So I listen to people's birth stories. I've been doing that for almost 20 years now, professionally, and publishing them. But this person said, this happened to me 14 years ago, and it's as if it was yesterday. I was laboring, and the doctor needed to do a cervical check and began the exam. And I said, ouch, that hurts. And the physician's response was, well, you're just not relaxing enough. And that's why it's hurting. And then continued to thrust their hands inside her vagina and poke around and cause more pain until the exam was done. Did not say anything to the person. And so what is the person on the having the exam done to them experiencing? They are saying, giving legitimate communication, ouch, that hurts. And the position and person in power is saying, does not stop, does not acknowledge the pain, in fact, blames them for experiencing that particular sensation. And instead of recognizing, wow, I'm putting my hands inside someone's vagina. In no other part of social existence does this happen except in obstetrics. And you're supposed to accept it, or gynecology, and you're supposed to accept it. And then you're supposed to use your mind to talk your brain out of having the problem. That you're supposed to talk yourself down so that it doesn't get encoded as traumatic. Because if it does, that's because you personally have issues, not because of anything I did to you. And the system,
don't speak up.
Yeah. So, even when you do speak up, you get poo-pooed and told no. I mean, when you're laying flat on your back and you're in labor and someone has their hands right there in your vagina and they tell you, don't move, it's your fault, relax. All of the hormones of labor, all of that oxytocin, all of that prolactin throwing in your system makes you feel like a sheep, because oxytocin only flows in trust and safety. So it's also one of the reasons why we have such a high cesarean rate and has such a high operative delivery rate, because cervixes do not like being examined, even during labor. And it's one of those things that people talk themselves through in labor in order to get over it, because we don't respect spontaneous labor, because we can just give somebody artificial Pitocin. So it doesn't matter if we stop your labor. It doesn't matter what we do to you. It doesn't matter if we don't respect the spontaneous oxytocin coming from your brain, because we can always give you IV Pitocin. Right. And for 40, 50 years, we never questioned the use of Pitocin. In the last 10 years, we've started to examine, well, what happens when you put artificial synthetic oxytocin in a laboring person's brain and in an infant's brain? Well, what happens is the mice studies are showing that they end up with a lot more depression and learning disabilities. So we may have been causing this whole issue with depression and learning disabilities, contributing to that in some way through the use of synthetic Pitocin. It's one of the things that's really emerging now in a lot of our university labs, is that research that it is not a benign practice, and it has an effect on our behavior, because of course oxytocin rules all of our social relationships and all of our intimate relationships, and of course how we behave sexually as well.
The implications for that are mind-boggling.
And that seems to put these Pitocin injections almost at the level of those sort of the cranial caliper traumas that often occur.
Mm-hmm. Yeah, I mean, the whole I don't want people to think that we're talking about, just like some evil practitioners that are callous or intentionally causing violence. The whole process is violent.
Mainstream.
I can't imagine
obstetrics.
how terrifying and terrorizing it must be for a woman in mid-labor, and the decision is made, no, we got to do a C-section, and just pull her out and run her to an operating room, and mm-hmm. Again, no explanations, no calming down.
One of the themes we have running through our society is that all that matters is a healthy baby. And when you say that to someone, what it does is it negates all the subtleties of the experience. It negates what all of our research tells us. Birth memories last. People remember 80 to 90% of what happened to them in detail as elders. So you interview 80 to 85-year-old people who gave birth, when they were in their 30s, they remember 80 to 90% of it. Mm. That's what all of the birth memory research shows very, very consistently over the last 30 years.
So and just to be clear, it is
so birth is remembered, and on top of that, those memories are instructive. They affect parental self-efficacy, so your ability to make decisions as a parent and feel confident in making those decisions. And they also affect the birthing person's sense of self-worth.
Wow. So that grand old myth that women don't remember the trauma of their
Oh,
Well,
childbirth.
because it's so
Nature
beautiful.
has a way of clearing out the memory and all that kind of stuff.
well,
It's just
the
not.
pain, yes, because you get that surge of endorphins. Now, this is if you don't have Pitocin and you don't have an epidural. If you've had Pitocin and an epidural, you don't get this, okay? But
Okay.
if you have not had those drugs in your system, you get a super surge of hormones right after the baby's born in that first half an hour. It's a surge of beta endorphins, it's a
Mhm.
surge of prolactin, surge of vasopressin.
Mhm.
And those are bonding hormones. They're the same hormonal cocktail that's released post-orgasm.
Right.
So if you can imagine that experience times 2000,
Yeah.
so that feeling of everything's great with the world, everything's wonderful. I love you so much. And that is the surge of hormones that bonds you to the baby when you are together. But women also can have this feeling, if I can do this, I can do anything.
Hmm.
And as Americans, we do not want a nation of empowered women, because if we did, we wouldn't do this to them during birth. But it's a systematic disempowerment of women, telling them what you want doesn't matter because you have a healthy baby. How you felt about what happened doesn't matter because you had a healthy baby.
And how dare you complain?
You have to get over that. We needed to do the cervical exam, and the physician is thinking, all I need to do is just get in and get out, and we could be done with this, without thinking, oh, this is like raping somebody because you don't have consent. In that moment, when that person in my training was telling me that story and she said, ouch, that hurts, stop. That was saying, I am revoking my consent for you to put your hands in my vagina. But that is not what the physician is hearing. The physician is hearing, if I could just get this done, I would be out of here and I could get on to the next thing on my list, because they don't see it as a process that needs consent. And they don't see it as a vagina that has the symbolic meaning that it does to the person's body. You may be the second or third person to put your hands there. But since they've stuck their hands up, hundreds and hundreds of vaginas, their sensibility to it, their sensitivity to it is eroded. And it doesn't matter the gender or the sex of the physician, because I've seen women be just as cruel. And I have, like I said, I've been witnessing birth for over 30 years. So I've seen my share personally. I had a debriefing session with a doula on Tuesday who called me and said, I witnessed something and I don't know what, I have got to talk to you about this. And so the client had a stroke in mid-pregnancy, and so was on medication for that. Because of the stroke medication and whatever other details about their medical profile that we don't know, was told you cannot take pain medication. So that was all right with this person. And so they made it through the labor and got to the point where they were pushing, and they're pushing on their side. So with the doula holding up the upper leg, so there's plenty of room. This allows the care provider to see everything that they want to see about the baby emerging, how the perineum looks, and so on and so forth. Side lying position is a very, very common position for labor and birth. Most people are, according to our last statistics, about 7 out of 10 people are told that they need to be in semi-sitting position and are not given any choice. Wow. The problem with semi-sitting position, which is sitting on your butt with your knees pulled back, is that it makes the area that the baby has to pass through much more difficult. Crimson. And the baby can't, rather than a straight shot with side lying where you've got a birth passage that's like this, now you've got a birth passage that's at a curve, and the baby has to go down and then come up under the pubic bone. So that's when you see tears, that's when you see a need for episiotomy, that's when you see pudendal nerve injury, that's when you're seeing incontinence issues like we see as therapists and educators afterwards. Almost all of that, any kind of tailbone injury, any kind of pubic bone injury, all of those things only happen in semi-sitting position. However, it's the throne position for the doctor. Obstetricians are supposed to be the elite because they're surgeons, but they only learn to catch babies in one position. Your doctors of osteopathy, your family practice doctors, your midwives, you could be standing on your head with a baby coming out and they will find a way to catch it. I know, I've seen it, and it's a part of the way that they do birth, but OBs don't do birth that way. So anyway, in this particular story, this woman had horrible hemorrhoids and had been really struggling with these hemorrhoids for the last several months of her pregnancy, and had asked the nurse and the doula, can I just be in side lying position? And so the physician came in, said, oh, needs to be in semi-sitting. It's like, look, she's got really horrible hemorrhoids. She doesn't want to move. There, progress is being made. Does this need to happen? And the doula even said, can you please give us a medical reason that she needs to be on her bottom? And the physician said, nope, that's just the way I want it. And so the nurse then reaches down and starts flipping over the patient's body. Well, what are you supposed to do as a patient? You can't resist in that moment. You're pushing your baby out.
Right.
So then the care provider insists on being in this position. And of course, then after the baby's born, her hemorrhoids are 10 times worse when that wasn't needed at all. That's obstetric violence.
Mm-hmm.
That's when there is no medical reason except the physician's preference, and it makes things worse for the patient's outcomes.
Right.
Absolutely. And you know what I can't get past in my head as you're talking about that and describing that as a position, it almost seems like these doctors don't really know the difference in process between having a baby and having a bowel movement.
Well, I don't know if I would go that far, Larry. What I will say is that they aren't focused on the person. And I have had several 45-minute, hour-long conversations with obstetricians who had high-level positions in ACOG, the American College of Obstetricians and Gynecologists, about what can doulas offer you? What do we know that could add to what you know? And the end of every single one of those conversations was that what the knowledge that you have of the person birthing or the patient is irrelevant to me, because I really don't care about the individual person. What I care about is getting the baby out safely. Right. Well, that's fine if that matches the paradigm of the person you're caring for. But that is not the attitude that the vast majority of people are bringing to their births and bringing to their practitioners. And you also got to realize that many, many obstetricians experienced emotional and physical abuse during their time as a medical student and during their time as a resident. That they were belittled, they were not allowed sleep, they were not allowed food, they were told that any emotions that they felt in response to seeing somebody being injured, somebody dying, they were belittled and degraded for that. So because they experience that as part of their training process, of course they feel that that's an okay way to treat their patients. Yeah. Because it's the way they were treated, and they're supposed to be on the top of the food chain as specialists. I mean, and the law says you can't even, if you have an unexpected outcome as a physician, you can't even say you're sorry. I'm sorry your baby died, because that implies liability, that you're saying that it's your fault. Right. And you're not allowed to communicate. Oh. So, the role of, we as a society have constructed this role. We have. Mm-hmm. And we have imbued obstetricians with this particular power. Part of deconstructing it and changing it is for patients and people birthing to take responsibility and become educated. Mm-hmm. But childbirth educators are gatekeepers. They're horrible that way. You have to be pregnant to take a birth class. And one of the things I've been talking about this year is like, no, if somebody wants to take a birth class, it doesn't matter whether they're pregnant or not. It doesn't matter how old they are. Let them learn, because that changes the dialogue out in the outer community. And that's where things need to change, so that you know about this before you become pregnant. Right. And realize, well, geez, I need to find out what my rights are, that you have rights, but people are treated as if they do not. Like the doula who is in the room, that doula has over 15 years experience, has been to, I'd say probably 300 births, has been a doula trainer for many different areas, and is an agency owner. And she needed to call me to debrief this, because she said, I had no say. There was nothing, it was like an immovable force with the doctor and the nurse, that was the way things were going to be, and we couldn't do anything about it because we just had to get through this birth. And that kind of feelings of being intimidated and being bullied, because that to me is exactly what it is. And unfortunately, like if you go to birthmonopoly.com, they've got a whole map of people saying this happened to me at this particular hospital. Mm-hmm. In my particular hospital, I know somebody 2 years ago who had a forced sterilization, a Black woman. And she did not request that. And it was done to her. And they did not give medical reasons. She had her child passed away. And so she wanted to go back and conceive again and couldn't figure out why she couldn't do that. And they said, they looked at her record and they said, oh, well, when we did this medical birth, they sterilized you. Didn't you ask for that? This is 2 years ago.
Oh, no.
Yes. And I mean, what we're hearing on from ICE, about forced sterilizations of people who are, I mean, you don't want to think this is happening in your United States, and you don't want to think that it's happening to white people. Carolyn Malatesta, she got $4 million last year. It was her fourth child. The physician hadn't arrived in the room and the baby was emerging, and the nurses shoved her knees together and kept the baby inside of her in the birth canal for an extra 4 minutes. The baby was fine, but the nerve damage to Carolyn is that she has incontinence of all three kinds, cannot handle intercourse, cannot handle any sexual stimulation, and cannot sit for long periods of time. That's why they awarded her the $4 million, because of the grief and suffering and loss to her marriage. And and she is a very empowered white person. And that's one of the reasons why she went public with her story and everything, and would not sign a non-disclosure agreement. Most people who sue and have to sign a non-disclosure agreement, so we don't hear their stories. But that's why they're on Birth Monopoly, is for people to read them and see them. Mm-hmm.
So if we can, because I mean, I would love to go on for days talking to you about stuff, but could you maybe, as a way of our kind of bringing this, unfortunately, to a close, what recommendations would you have for women who are going into a birthing scenario, who are going to have a baby? How can they empower themselves in these situations?
I would say that you really have to choose your care provider carefully. And if you're involved in an insurance system that does not allow you to do that, you are either going to have to make a choice to get more involved, to make sure that take the Know Your Rights course, find out what your rights actually are, what your power is in your insurance system, to locate the care provider who you want to. Your other choice is to exit that system and pay cash and for a midwife. And so to where I live, home birth is incredibly safe and incredibly effective. So, and we have great midwives. So that's one of the things that people don't normally think of. They think, oh my God, that's only for hippies or, ultra conservative Christian people or Amish people or whatever. It's like, no, it's great to birth in your own house. It's like, it's the most empowering thing ever, because everybody's a guest. Mm-hmm. And people think, oh, you can't handle the pain. And I'm like, well, when nobody's screwing with you, well, it's all the cervical checks and the incidental touching and the IVs and stuff that cause you to have pain, because they cause the stress hormones. Mm-hmm. And so I'm not saying it's not painful. I'm just saying it's very, very different. So I do want to encourage people to explore their options. And if they think, well, I'm too high risk, I could not do that, then you just need to choose your doctor carefully and then take a doula with you. And that is the other thing. Doulas are trained advocates. So we know how to talk to care providers, and choose your doula carefully. I mean, that was one of the reasons why I was chosen. I had anybody who had a chip on their shoulder about medical people, because I get them. I understand their perspective. I understand the pressures that they're dealing with. And how they are degraded and not honored and don't get the resources they need to deal with secondary trauma at work. And so it's a system that doesn't really work for anybody except the system itself. So that's what, that's one of the things I would say, figure out what's going on where you are and find your options. Lastly, a lot of our rural hospitals have great have great labor and delivery units where you're going to get one-on-one nursing. And I'm talking about places that have less than 300 or 400 births a year. So whereas I live in a small city, if I was going to give birth today, I wouldn't want to go to one of our large hospitals. I can think of 3 that are just right outside the city where I would have a much better experience. And you've got if you want medication, you can have that. If you need basic interventions, they can do that. They just aren't going to have a neonatal intensive care unit. So if you are truly high risk, then needing to be in a larger hospital is important for you. And then so is making sure you have your labor support. No, there is one more thing I'd like to say about COVID.
Mm-hmm.
So, and that is that COVID has really, really revealed what hospitals are patient-centered, that are keeping options such as water birth, laboring in water, using peanut balls, having a doula present, and then hospitals that are not patient-centered. And those are the ones that are only telling you can have one person in with you, no doulas, we're not doing water birth here anymore, we're not offering options. Those are the ones you really want to stay away from because they don't care about you and they don't care about the quality of your experience, and they're making it very, very clear through their restrictions. So if you have the option, and you can always go to Tennessee to Ina May Gaskin and Birth at the Farm Midwifery Center.
Ah, nice.
That is, and there you pay cash, and you can work in their vegetable garden for 2 weeks before your due date. And so you have more options than you think you do, as long as you're stretching your definition of what options are.
Excellent.
So.
Oh, well, thank you so much.
Really,
and I'd love to definitely talk more. We'll have you back again. We'll talk more about midwifery and doula work.
Not just this amazing work in this field that way few people know about, but you're even a unicorn in this small field because you're also a sexologist. So you have to come back and talk more about sexuality after going home with the baby, or getting rid of the guests. And yes, please, let's continue this for a part 2.
Oh yeah, I just completed a huge literature review on perinatal sexuality. I think I've read 1,500 papers now.
Wow.
1,500. Everything that's ever been written on the topic, and everything that's ever been written on the topic of fathers in birth, fathers in pregnancy, and fathers in postpartum.
We'll definitely talk to you more about that as well.
Yeah.
That is,
what was I gonna say? Yeah. Oh, I think it would be great to talk about sex in birth, because ASECT is so not ready. They have, when Orgasmic Birth came out, 3 times I tried to get it to show it in the film festival, and they were just like, no, they didn't want to go near that. And I'm just so disgusted. I'm just really disgusted. So
yes.
with that.
We live off of outrage and frustration.
Right.
Yeah.
Right.
So glad you're in our ranks on that.
Yes.
Yeah, I'm really glad to reconnect, and let's stay connected.
Yes.
Yeah. Take care.
Real soon.
Yes, indeed. Thank you so much, Amy.
Sure.
Eye-opening indeed.
Yeah, very powerful subject, very powerful lady. We're very grateful, Amy. Thank you for your time, and it was really wonderful to see you again.
Indeed. And how about a sake toast to Amy and the work that she's doing, and all of you who do that kind of work as well.
Cheers.
And I think it's really important that we all realize, but women especially, need to understand how so much of your own agency, your own control is taken away from you in that whole birthing circumstance, almost from start to finish. And there has to be a way, and Amy gave some good suggestions, but it does seem right now it's kind of limited. But we have to change this system to where women can have more control over their bodies, more control over what's happening during that birthing process. I was really floored by how it just seems so many women are, and I can't describe it any more plainly than just taken advantage of.
Yeah.
and completely invalidated and discounted in terms of their humanity. Just because they're giving birth, they're bringing more humanity into the life.
The baby, they gotta bring a healthy baby in.
Right.
Nothing else matters.
Right, and the mother's care and the mother's well-being be damned.
Well, like just about everything else we talk about in Sex Talk, for a country that prides itself on being the greatest country in the world, and we're number one, we so lag behind most of the rest of the industrialized world when it comes to matter-of-factness, comfort,
Absolutely.
ease of discussing every aspect of sexuality.
Right.
And not surprisingly, women have better, healthier birth experiences in European countries than they do here in the greatest country in the world.
That's right. And we've talked about this before from the standpoint, I think one of our first poetic justices that we did with Sex in the News in talking about Ted Cruz. And I think this is a very American thing too. Looking at Texas, how among all the states are some of the most resistant to these sexual health strategies, these sexual health programs. And is it no surprise then that the most resistant state in our country sports the highest rates of infant and maternal mortality in the world? So you get what you pay for, don't you?
You get who you vote for.
That's exactly right.
Yeah, so I think that's going to do it for us for this week for Sex Talk with the Siegel Brothers. We thank you for joining us.
And stay well.
We'll be here next Friday and every Friday at 7 East Coast time.
Thanks for watching Sex Talk with the Siegel Brothers. Join us each week on Friday at 7 p.m. Eastern. You can also follow us on Facebook and subscribe to our YouTube channel to stay on top of the latest developments in the ever-changing world of sex and sexuality.